Hello everybody, and today we're going to talk about guided surgery from the Bronnemark Centre here in Perth. Guided surgery, right. This can be an itsy-bitsy approach using a multitude of navigation or guide concepts applicable to a given case. So that today in the marketplace there are many navigation devices and there are different sorts of guide concepts that you can use now and again to treat a case perhaps. Or alternatively, guided surgery can be a total concept in your practice, which is applicable to all case types and universally adaptable to any totally or partially edentulous situation. So there are two alternatives here. One, as I said, to use something now and again, or two, your whole concept in your practice can be geared up to guided surgery. And of course, this is dependent on a number of factors, and we're going to talk about some of those things this evening. Mainly what we are concerned with is Noble Guide, which is a Noble Biocare development, and we will talk about that together with a few other things. So for many of us, this is perhaps a new way to think. There is a range of possibility for Noble Guide. This can be model-based. Don't worry if you don't understand what that is, we'll talk about this in more detail, but essentially model-based is the simplest way to go about doing this. This involves drills and sleeves that are made in the laboratory into a dental cast, and a stent is made in the laboratory either in your own in-house facility or the dental lab that you deal with. On the other end of the extreme is a computer-based approach, like we see here for teeth in an hour. That's what TIAH means. This involves computer planning. It involves making a surgical template, generally in an industrial complex. A surgical index is required. Sleeves and drills are, of course, available. And a permanent Procera implant bridge can be used, supplied with special abutments. So this perhaps then is the other end of the extreme. The computer-based blue box is one end and the red box model-based is the other end. And of course, in between we have a whole spectrum of possibilities for computer planning. Maybe using some sleeves, maybe just using an R stent, which means a diagnostic stent. So when we look at this whole spectrum, this means there are many, many approaches to Noble Guide that we can use in a lot of different ways. Another way to perhaps consider this is analog and digital, where at the laboratory consideration end, which is the red on the left, we use analog technology. Analog technology refers to all of the stuff that we've used forever in the dental lab, doing our crown and bridge work, doing our denture work. This is using analog principles. Whereas on the other end, digital, this means digital planning, digital manufacturing, and so on and so forth. So we could also look at this spectrum from that point of view of technology. With Noble Guide, there are many prosthetic options for us to consider. It's not just a sort of yes-no choice. There are many varied options for different implant systems too. At this stage it is just for the Bronnemark and the Noble Replace systems, but other implants are possible. The first thing for us to consider is, with our prosthetic option, do we want to go totally, completely to the final prosthetic option? Or do we want to go to a temporization or provisional level of treatment? If we consider the final level of treatment, this means going to Procera and teeth in an hour, which a lot of you have seen at different clinical conferences demonstrated. What you may not understand is that Procera teeth in an hour has a number of possibilities, and we will develop this a little further. But at this point of time, in principle, we can either have a screw retained restoration or we can have a cemented ceramic restoration. On the temporization pathway, we can go to an abutment level or an implant level planning of our prosthetic work. At the abutment level, this can be screw retained or cemented. Of course, at the implant level, by definition, if we're going directly to the implant head, this means screw retained restorations, because we can't cement restorations directly onto the implant. With respect to these different sorts of restorations, there are very many different abutments that are available, and here are some of them. We're not going to talk about all of these, but here's an example, and these are applicable to either the Bronner-Mark system, as you see on the left, or the replaced tapered system, as you see on the right. The two abutments that we're most going to talk about with respect to teeth in an hour would be the guided or the Procera abutment. With respect to other possibilities other than teeth in an hour, we may consider some of those other abutments. So how do we decide the choice between the so-called guided abutment and the Procera abutment? Again, if you are thinking to yourself, what the hell is a guided abutment? Don't worry. This is just an overview and we're getting to the detail on this stuff. But what is important for us to begin to get into our mind now is to use a guided abutment, we need 8 millimetres between the bone level and the opposing occlusion. That is 8 millimetres to put in prosthetic work. If we have 8 or more millimetres, we can do guided abutment prosthetics. And this is an advantage. This has got certain advantages. However, if we don't have 8, if we have 7, 6, 5, 4, 3 millimetres, we can't use the guided abutment, and we have to use Procera abutments. Or, if we have less than 5, we can't even use Procera. And we all know we have some tight space situations with less than 5, in which case we won't go to the abutment level. We will go direct to an implant level and we won't be considering any abutments at all. And we look at that sort of thing later. Now, there are 4 levels of guided surgery for us to consider. And the choice of what we might use depends on a number of factors. The first is the level of case complexity. And this may be different. A single tooth, of course, is probably the simplest, least complex of any implant restoration. On the other hand, there will be people in our audience that will say, no, it isn't. The single tooth is the most demanding. Well, maybe for some people it is. But going down this sort of procedure here, our sequence, we would say, okay, a single tooth is 1 implant. We can use more than 1 implant, so maybe do an overdenture. We can get into partial edentulation. To me, partial edentulation is the most complex. Why? Because it involves the rest of the mouth, not just implants. What we have found in our training courses is that the biggest shortfall of information is with general dentists trying to undertake full mouth reconstruction procedures on teeth and implants simultaneously. This is the most complex work. Full arch work, of course, means a full arch bridge, and if you've got a full arch bridge in both jaws, that means full mouth. And then on top of all of that, we have the consideration of immediate function. Do we want immediate function? Because we don't have to immediately load implants. We may use guided surgery just to place the implants and do 2-stage surgery if we want to, or do a single-stage surgery but not load the implants immediately. So the first consideration then is this level of case complexity. Our next consideration is the level of radiological examination that we have to do. We may just need to do a Panorex. For example, if we're doing a single tooth implant, many of these sorts of things we would do with maybe just an intraoral periapical radiograph and maybe a Panorex. If we're doing an overdenture, we may just do a Panorex. If on the other hand we're doing more complicated things, say we're putting implants in the posterior mandible close to the inferior dental nerve, we may consider some sort of scan, a segmental scan type thing, or a scanora or a cone beam device. And the reason we would consider those things is because we're doing a segment. Or if we're doing a whole mouth, a whole archful, we may in fact do a 3D CAT scan. Now, ladies and gentlemen, please consider what we have down here. Consider dose, cost, and the patient's best interests. What we're referring to here is that the dosage of radiation that the patient is going to receive in these different levels of examination between a Panorex and, say, a 3D CAT scan is enormous. Some 3D CAT scans, depending on your machinery available, may give the patient the equivalent of over 100 Panorex x-rays. On the other hand, a Scanora or a cone beam may give the patient the equivalent of 5 to 10 Panorexes. But maybe they're not always available, maybe they're not applicable. What is important is to decide the level of radiological examination which is in the patient's best interests, and not what particular machine you might have in your office, in your in-house facility, that you've got expensive lease payments to meet, and therefore you decide you want to use that machine, and you really don't care about the patient. And of course, cost is important. In many countries, if you send the patient to a radiological clinic and they have appropriate insurance, they may get that radiology considerably cheaper than if you try to do it in your own office. So anyway, the point here is not for me to preach to tell you what to do. The point is to look at this sensibly and rationally and decide what is in the best interest of the patient. And my last word on that would be, we don't do the same thing every time. We consider our radiological examination for whatever the case at hand is. The next consideration on what level of guided surgery to consider is the in-house lab facility. Do you have your own laboratory facility at all? Do you maybe do some lab work? Do you employ technicians? Do some of your dental assistants do some lab procedures for you? Or do you send it all out to a commercial lab? So, depending on what your capability is, will depend on maybe what you can do in-house. And the other consideration is the level of digitalisation in your dental office. Today we know that many dental offices are almost totally digital, which is fantastic. But there are still many dental offices that are just getting into digital possibilities with respect to equipment in their clinic, with respect to equipment in their office, and maybe even with respect to equipment in their laboratory. So that level of capability is also a consideration. So keeping these sorts of things in the back of our mind, let us now look at an overview of Noble Guide, of a summarising overview. So we can do guided surgery on single tooth or missing tooth, multiple missing teeth rather, or all teeth missing, any of those situations. And we can go down to a model-based or a computer-based level of planning. And from there we can pick what implant system we want to use. We might want to use a tapered implant. We might want to use a parallel implant. We might want to have an internal prosthetic locking system. We might prefer an external hex, and so on and so forth. Different reasons to pick different systems. And finally, the most important thing, do we want to go to a final restoration or do we want to go to a provisional restoration? That is a key question. Okay, let us now look and overview these different levels of guided surgery. The first one, conventional laboratory fabricated surgical guide. What this means is that you and I would do this in-house, or we would send it to our local sort of prosthetic lab. This is not high-tech crown and bridge. This is not top-end aesthetic dentistry. This is sort of fairly routine laboratory work. So what we see here is a case, and we're talking about this situation up here where we're going to place implants up there into this area. And we think we're going to put 2 implants into what appears to be quite a good area of bone. And you see on the study cast we have drawn a couple of lines through where we think the implants would be placed. And by measuring just a Panorex or even an intraoral x-ray, we know we've got at least 15 millimetres of bone up there before we get anywhere near any sort of important structure. So the next thing we're going to do is so-called mapping of the soft tissue. And what we do here is we have a vacuum form. And you see in the vacuum form we inscribe some points along the lines of where we think we're going to put these 2 implants. And of course in this situation we would put 1 implant here, 1 implant there, because we want to be far enough away from this tooth molar, this tooth cuspid, so that we do not endanger the tooth roots. And we want enough space in between the implants so that we have a very good opportunity to get a good aesthetic form and to perform hygiene through there and all of those other factors. Then we go to the clinic with this simple vacuum form, and where we have these red marks we go through and we perforate them. We put it in the patient and we can either perforate that directly or we can drill small holes through there before we go to the mouth. And here we have a probe. We're doing tissue sounding. Needless to say, we want to have some local. And you see up here there is evidence, that red spot, that we've given some local. You sure don't want to do this without local or the patient will never come back. So here we see we are now done the mapping in the mouth, and as we do this we call out each time with our probe to our dental assistant. Starting on the first implant, starting in the palatal, we will say 4 millimetres, 4 millimetres, 3 millimetres, 3 millimetres, etc. And she will record that according to the perforated template. So this is very simple technology. Then what we will do is we will transfer that data to the study cast. So here is a study cast. And here you see we've got 2 lines drawn on there, and we have these mesiodistal lines along there which intersect. So we will be calling out each of these points to the dental assistant. 5 millimetres, 4 millimetres, 3, 3, maybe 2.5, 3, 3, etc. And then we will transfer this data then to the cross-section of the cast. You see this cast has been divided with dowel pins. So these are removable segments which will contain the installation site of the implant, which will be down here. Here you see now we are measuring on the stone cast what we have called out in the clinic, and then we will grind that away and we will reduce this. See, it's reduced down to here. And then we know we are going to put an implant in there. In this case it's a Bronnemark implant because you see an external hex is there. And then we will go put those implants into the cast. And then over here on the right you will see that we have got a couple of guide pins. The next thing will be to reconstitute the cast with respect to the tissue section. So here you see using a bit of silicone rubber which we inject inside the template. We put that back on and we formulate the gum. Then down at the bottom here using a tissue punch we will perforate through that gum into the implant position. Then what we will do is in the laboratory we will now construct our surgical guide. So what we have here are these devices, the so-called pin unigrip, guide sleeve and cylinder. What happens is that this goes into this goes over that, and the screw thread of course goes down into the implant. So here we see this. Here is the top of the pin unigrip, here is the sleeve, and here is the screw, screwing it down into the implant. So that this will be put into position, and then we will either do a vacuum form over there, or we will do make a light cured tray or something like that over there, and the sleeve of course will be, that sleeve down there will be incorporated into the plastic as we see here. And then if we're doing acrylic, as we see it down the centre of the screen, that's what we'll have. And then we will cut off the excess acrylic and we'll polish that up. And then we have a nice removable template with these two sleeves in which will guide the implants, and that is in fact our surgical guide for a simple exercise like this. We can also do the same sort of idea with respect to, say, an overdenture. So a mandibular overdenture, we would do sounding, tissue sounding, bone sounding in the same manner with a clear template, transfer that to the study cast and make this surgical guide, which is then put into the mouth at the time of surgery, and then of course we just drill straight down through that guide and into the jawbone in a total safe and predictable way. So that is something which is applicable to a lot of dental offices and certainly is applicable fairly easily in the posterior maxilla, the anterior maxilla, the anterior mandible. Perhaps if you're going close to the inferior dental nerve, you don't want to use that procedure. Another indication for this will be in those countries of the world where we don't have the availability of sophisticated radiological devices like CAT scans or cone beams. Or in some of those countries where we do have that, like for example my own country here in Australia, we have those sorts of things available in the major capital cities. But when you get out back into the bush where there aren't many people, there aren't many dentists, well, you can rest assured there certainly are no CAT scans available. So in those sorts of remoter areas of the world, and maybe some underdeveloped countries of the world, type 1 will have a big application. So let's now look at level 2, which is scanning with 3D planning plus a conventional surgical guide. So what we have here is a edentulous patient, and we have duplicated the patient's denture. And in the centre third of each tooth, we've cut out a section to make a radio-opaque area. And you see here that this radio-opaque area shows up against the ridge. And over here in this section, of course, we can relate the tooth to the residual bone, to the implant, to the thickness of the soft tissue. We can do all of those sorts of things. And we make this sort of surgical guide, which is a common guide that many, many people around the world advocate. And this is applicable for either a complete jaw or it is applicable for a single tooth. Same sort of principle. For a single tooth, you would do make some sort of an acrylic device with a replacement tooth, and you would make that tooth radio opaque so it shows up on the x-ray. And then, certainly in our centre here, we then do all of the drilling through the template exactly. As you see here with these centrals, we're right in the middle of the centrals where we want to be. We may take this in and out to double check things, but essentially all instrumentation and all implant placement, as you see here. Here is an implant in position with the implant mount or the fixture mount on. This is done with the template in position for precision. And then when we finish that, what we would do, of course, is do a pickup impression, and in the laboratory we would make a bridge. And we would get this temporary bridge put into the patient's mouth ASAP, which may mean later that day or certainly the next day. If you want to leave it for 2 or 3 days because it's over a weekend, well, you can do that. But we get this bridge on as fast as possible. Right, as we now move up in complexity and we talk about 3D scanning using a CAD/CAM surgical guide plus a conventional bridge. So now we are using the Procera software scanning program. In this instance, what we're going to use this for is to do the planning, relate the implants to the bone. This lecture is not a lecture on how to do this. This is just a lecture illustrating what we can do with this sort of stuff. So we would do the planning, and then we would make a surgical template. And so this surgical template is industrially made with the Procera planning and Noble Guide. You would send your data by telephone to Sweden, and they would make this surgical guide, and then it would come back to us. And we make a surgical index, which is this piece of rubber for the patient to bite against. We'll look at that in a little more detail later. And then we will do all of the drilling in the mouth through these holes and put in the implants. And in this case, we're putting on abutments as well. And then what we will do is do an impression in the usual way, some sort of pickup impression like we see here, and we'll go ahead and make a provisional bridge and get that provisional bridge inserted, as I said, at our convenience. It might be today, it might be tomorrow, it might be in a couple of days' time. It is also possible to have a preformed shell bridge made, and you can do this connection directly in the mouth if you want to, but we prefer to do it in the laboratory to develop better emergence profiles, better submergence profiles, and so on and so forth, as well as better aesthetics and a stronger device, because in the dental laboratory we can process acrylics and use acrylics with much more flexibility than we can directly in the mouth. The final option then is a total 3D scan, surgical guide, and using an immediate Procera implant bridge for the so-called teeth in an hour. So this is the far end of the spectrum. So here we see a patient, and let us consider for a moment how we might plan this patient who is interested in getting rid of her complete denture in the maxilla. We look into her mouth. She's got a nice mouth, nice ridge, but that's the last thing we really want to see. The most important consideration in this situation is, one, the patient must be happy with existing denture tooth aesthetics. If the patient doesn't like the teeth because they're too short, they're too long, they're too twisted, they're in the wrong position, she's too closed up, or she's too open, or any of those other things, we must make a new denture or correct the existing denture. The only deficiency that we will accept on the existing denture is maybe tooth colour. If the patient says, I'm happy with everything, but I want A1, not A3, or I want B2, not B1, or something like that, that's okay. The tooth colour doesn't matter. But tooth position cannot be changed later, because we are going to make a bridge into the exact position of the existing teeth, which means the existing denture. Next thing we will look at is that the denture must be stable, must be good occlusion. If it isn't, you've got to adjust the occlusion, or you've got to add on some composite to stabilise the denture. And it must fit well. And here's a word of warning. Don't think just stuffing a bit of tissue conditioner into the denture will make it stable, because those tissue conditioners will come out and blur the CAT scan. So you must reline the denture with proper acrylic. So many dentures that come in, of course, are unsatisfactory. So what we say to the patient is, well, the first stage of treatment is to make you a new denture that you're going to be happy with respect to the stability, the fit, and the tooth position. If they say, I don't want to do that, I want to get straight on with my implants, well, what I tell them is, I say, I'm sorry, we can't do that, but here is my telephone book. The yellow pages in my telephone book, I turn to D for dentists, and I pull out 20 pages of dentists, and I say to the patient, here, go find yourself another dentist, because you don't need me, because we are only going to do this properly, or we're not going to do this at all. And properly means getting your denture right. We then take special note of the patient with the denture in and the denture out. We are looking for the effects of the denture on the facial morphology, the lip, the philtrum, the support of the upper lip under the nose, all of those things. And what we like to do is to see, if possible, that there is not a lot of difference. In patients where there is not a lot of difference, we like to treat them. If there is a huge difference, well, we have to be very careful, because it might mean the patient needs pre-implant augmentation. But this patient here, this is what we like to see. Okay, there's a little bit of difference here on that contour, but not very much. No real difference coming down here compared to with the denture in. And the other thing to look at is the lip. The outline of the top lip and the amount of lipstick not much difference with denture in and out. So this is a very favourable patient. And then the smile line, what we're interested in seeing is how far back do we go? If this patient smiles and we see the third molar tooth on the maxilla, wow, this is very complicated. If on the other hand it's like here, what we're seeing is only to the second premolar, or maybe the first half of the first molar, mesiobuccal cusp of the first molar, we know this is good, because all we need to worry about in occlusion is a 6 to 6 occlusion. We don't have to go back to the 7s and the 8s. This could mean less implants. Okay, so we can also measure the thickness of the labial flange if we wanted to get an idea. And then the next thing we do, which is very important, is what we call interchangeable mounted casts. What we want on the articulator is the full information that is in the patient's mouth. So what you see here is this: lower cast, upper cast. These are simple alginate impressions. Here we see upper denture, existing denture, and into this we have poured a cast of silicone rubber because there are some undercuts. But because this is a laboratory rubber here, this denture will click on and off with ease. And so what we do with these things then is we make interchangeable mounted casts. So what do we have here? What we have here is the relationship of the existing upper denture teeth to the lower teeth there. Then we've mounted the denture. We take the denture off, of course, give it back to the patient. And now what we have is the relationship of the maxillary ridge to the lower teeth. The relationship of the incisal edge to the crest of the ridge. All of this information, we have all of this in front of us at, most importantly, at the correct vertical dimension. So this is not a big deal. This is a fairly simple laboratory exercise. All you've got to do, you don't even have to do an impression except for the mandible. Take an alginate impression of the mandible and then send that with the denture to the dental lab. They'll take an impression of the denture, they'll pour a cast into the denture, and they do the mounting. I mean, what could be more simpler than that? You sure don't have to dick around with base plates and occlusal rims and all of that sort of rubbish. You don't do any of that. That's too hard. Then into that denture, you see we have got some little radio-opaque markers, gutta-perca markers, and you see that on the radiology, those gutta-perca markers come out. And this is what is used in the software to relate the denture and the teeth to the patient's bone. So essentially what we do then here quickly is, here is the denture in position. We plan all of the implants to come out of the occlusal surface here and to come out of the lingual of the upper anterior teeth here. Then we can remove the denture and we can see the relationship of the implants to the bone. What are these yellow things? They're not tooth roots, of course. What they are in the planning is a thing called a safety zone, which means if you're going to perforate the bone, you have a 2 millimetre guide of a yellow safety zone around the implant. So if you see yellow, that means you are less than 2 millimetres away from the surface of the bone. And of course, if you see the implant, it means you have perforated completely. So here you see there is a little fenestration, slight fenestration. This you would see maybe, as a potential dehiscence if you move the implants further to the labial. And then we have, as we said before, down here we have a surgical template, an index, and down the bottom we have a bridge. The bridge over here, a preformed Procera implant bridge. Right, essentially what we do then at the time of surgery in 1, top left 1. Patient bites together on that surgical index, they hold the template into position. We screw that into position with so-called anchor pins. Here are these channels through which anchor pins down here are put into position. They are put in horizontally into the jawbone, 3 of them, and that holds the template into position. And then all of the drilling is done through those sleeves, and eventually implants are put through the sleeves. And then the implant installation is completed, up here in diagram 1 again, and you see the 6 holes where the implants have been placed. And then you see the bridge in diagram 2. And then that bridge is put up, pressed up into position into those installation sites. The patient bites together, holds it into position, and then we screw all of the abutments up. And then we check the occlusion, and that's what the bridge looks like. So it's a preformed bridge. What does this mean to the patient? Well, there are some real advantages. No cut, no stitch, little discomfort, little morbidity, little swelling, because you see there is no flap. So there is a minimum of swelling, there's a minimum of bleeding, because those bridge abutments fit in to those installation sites. The patient is almost unaware of blood. They even tell you a couple of hours later that they don't even taste any blood in their mouth. Immediate function and quick, 30 minutes. You might think that, you know, we're trying to sell something here and that we're sort of raving on a little bit, and this is not true, but it is true. Many of you have seen demonstrations of this procedure at different conferences, and we have treated some patients that it only took 25 minutes. In fact, our fastest one's 23 minutes. We don't care about the speed, it doesn't matter. Whether it's 25 minutes or 30 minutes or 40 or 50, it does not matter. The point is, it is teeth in an hour. We tell the patient, on the day of surgery, you will come in and you're going to walk out about an hour later and you are going to have teeth in your mouth. You're going to have immediate function. And they love that. Right, what does this mean? This means today we can do this for either full jaws or partially edentulous jaws or single unit cases. So here you see this patient here, single missing tooth, single missing tooth, anterior missing teeth. Here's the planning on this patient. So this patient is going to come in, and what we are going to do is put in 2 single tooth implants and anterior implants. So this is no longer just for the fully edentulous jaw. The technology has now been adapted to the partial edentulous state, so we've got a lot of flexibility. So let's consider some possibilities. Thinking about our flow chart here that we mentioned before, of course, what this means is that we can look at this chart as we discussed, and we can go to any of those possibilities that we talked about. So what we're going to do now, ladies and gentlemen, is to have a few examples of different things. We're going to go down the final pathway, showing Procera teeth in an hour. We might go down the temporization pathway, the other way, to show other possibilities. So we'll look at a few different examples of this. Okay, let's see example number 1. And keeping in mind our abutment selection possibilities, and keeping in mind the dimensions that we mentioned, about 8 millimeters for guided abutments and 5 millimeters for Procera. Just keep those things in mind, and now let's have a look. Our first example we're going to go to is a screw retained restoration. We're going down the final pathway, Procera teeth in an hour to screw retained. So let's see what we got. So what we have here then is exactly as we did on an edentulous patient, but we've done it on a partially edentulous patient. So what we see here is a bridge. This was the bridge. It's a 3-unit bridge, 3 implants, 3 units. Here's the radiology of it. And here's the guided abutment. Now this is interesting, we're going to talk about this. So let's consider now what is happening. We can do all of this planning on a computer, and we can make all of this prosthetic work before the patient comes in on a computerized model. That is all virtual reality stuff, which is fantastic. That's what we do all the time, but it is virtual reality. On the other hand, when the time comes to put all of this in the patient's mouth, we have clinical reality, don't we? And so the question might come up, in all of these stages of, say, computer planning, taking x-rays, taking impressions, making surgical stents, making radiological stents, making prosthetic work, there must be error. There must be a whole lot of errors of magnitude or magnitude of error in these different stages. And of course there is. And you might ask the question, what is this magnitude of error? What are we talking about? What is a big error? Well, the Noble Guide teeth in an hour system can correct errors up to about 1 millimetre. But generally the sort of error that we would see in the system is round about 300 microns. And so what that means is that if we put in these implants, okay, and we've got a bridge that is pre-made, and there is going to be some error. Supposing, for example, it's 1/3 of a millimetre. Supposing it's 1/2 millimetre. How do you cater for that? Well, the guided abutment is the secret of what happens. Look at this abutment now, and there are some things to consider. You see it has got like 4 flanges that come up. They stick up vertically. Here, 1, 2, 3, 4, looking at it from the top. And here is the screw that goes down this abutment. So what happens is, here is the abutment in the bridge, and what we do is we press the bridge to seat, and then we do up the screw. And then what happens is that these flanges spread out. You also see there are some sharp threads here. And these threads you may just visualise on this x-ray perhaps. They're sort of up here. And what they do is they engage. They engage on the inside here, this inside of the posterior implant bridge, the titanium. They engage and bite into that. They're like teeth. So what is happening is that when we screw up this special guided abutment, it actually moves in 3 dimensions. It moves axially, and it moves up and down, and as we do the screw up tighter and tighter to the recommended tightness of 35 Newton centimetres, the bridge goes down into position and ends up fitting perfectly because of the medium of the guided abutment. So that is the advantage of this guided abutment. It enables us to do this. If we didn't have the guided abutment, we could not do this. So the guided abutment is in fact the key. Okay, so that's one example. Let us now look at another example, another pathway, temporarization. Okay, that was final. That means that that bridge that the patient got, they walk out with, it's completed. That's it, the finished restoration. Temporization pathway, we're going to go down here now, and what we're going to do is go down to an abutment level, and we're going to go down here to a cemented bridge. So let's see what we're talking about here. What are we talking about? What does this mean? Okay, well here's a patient. Unfortunately, she had a 4-unit bridge on 2 lateral incisors, and she had an altercation and they were smashed out, and she lost the bridge, and she wants to have it replaced. She had a partial denture for a while, however it didn't work, and it was she was sort of interfering with her work. What is her work? Well, she is a sex worker. She's in the sex industry. And unfortunately, that's how she lost the teeth, because there was some sort of altercation. And then she finds that a denture interferes with her confidence at work, and she's got to get rid of it. She has to have fixed teeth. So we did the same thing on this patient. We did the planning. Here you see the planning, and we have planned for 2 implants into the central incisors, and we are going to have an anchor pin there in between those central incisors. Maybe we could have put an anchor pin into the lateral site, but the lateral sites had nothing in there ready to anchor them, because there wasn't anything in there that would anchor the site. So we've gone between the centrals into this bone. You might say, wait a minute, this anchor pin is right bang into the nasopalatine canal. Well, it isn't. It's missing the nasopalatine canal, which we could see in another angle of the planning. Anyway, what sort of restorations are we going to do for this patient? Well, what we're doing for her is we're going to make procera zirconia abutments. And we're going to have an acrylic temporary bridge, a shell bridge, which we're going to reline in the mouth later. So this is what we have before surgery for this patient. We have a surgical template, we have a surgical index to hold the template in a position. We've decided on these abutments that we've done in the normal procera scanning way on our cast, and we have got a temporary shell bridge that we're going to reline in the mouth. That's the plan. So this gives you an idea of the sequence here. Here is the occlusal index, the surgical occlusal index biting against the surgical template. That's where the anchor pin's going to go. This goes into the mouth. We say to the patient, bite together, bite all the way up, and then we put that anchor pin in. That holds that into position. And then we start drilling through the sleeves. Here we have one implant in position, and then later on here is the second implant in. And then down here, the surgical sequence is finished, and down the bottom what we have is the zirconia implants in, and the temporary bridge is in there, down here. Okay, so that gives you some idea about that possibility of the temporization pathway. So let's now consider another possibility, cemented ceramic. When would we do this? Well, remember I said for the guided abutment, like we just saw here, we needed 8 millimeters. Let's have a look at another possibility that we can consider when we don't have 8 millimeters, but we want to go to final treatment. We want to go down the final pathway. So let's look at this possibility. Very interesting patient here. 41-year-old guy. He has had conventional crown and bridge work up here and conventional crown and bridge work down here, and he has had endodontic complications. He has had post-cause in, he has had endodontic failure, he has had root fracture, and he has had his conventional treatment removed. Do you think he's happy? No, he's miserable. But he wants teeth replacements. So he is here now to consider implant treatment. We're going to give him immediately loaded implants. And you might say, you're crazy. You are crazy. This guy has smashed up conventional treatment because, of course, he has got a bit of parafunction and he bites hard. But you're going to say, to do immediate function on this guy is crazy, it's going to fail. Well, if you don't do it properly, it will. But with precision planning and proper treatment planning and employing proper concepts, we expect success, and we will have success. Taking this in a bit more detail, what we do now. Here we see our guy, Paul, the name of the patient. Paul is here. We have set some teeth up on a base plate, and then we check the occlusion on those, and that's okay. Then what we do is we open the vertical dimension up by adding more acrylic anteriorly here, and this is to separate the teeth radiologically, because the teeth will otherwise overlap and we will not be able to get precise occlusion. Here, through the front of the template, the red arrows, we have some inspection windows. That is for us to look in and make sure that the template is all the way seated. And here we have radiological markers, gutta-percha points. And the final thing we do is we put in some occlusal rubber material to stabilize the radiological template. So when the patient goes to have a CAT scan, the patient will put the template in his mouth, he will put the rubber in the mouth, and he will bite together. And it is absolutely 100% in position and cannot be distorted. Now we look at the radiological planning we're doing on him. Here we see the edentulous area. Here we see the template superimposed. Here we look at the important anatomical structures, cross-section of the mandible, What's that thing there? Inferior dental nerve, isn't it? What's this here? The mental nerve. We want to stay above those structures with our planning, don't we? So the first thing we do is we track the nerve. Here is the inferior dental nerve. That's it here. There. There's the mental foramen. Here's the mental nerve coming out. Here is the incisive nerve going around the front of the jaw. So we track the nerve. So here you see the nerve here, and here you see the yellow on top of the nerve. So this is a safety zone, a 2 millimetre safety zone on top of the nerve. So here we're beginning to do it. We go along here, we plot, we go click, 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 and we go all the way along here and we plot that. So do I do this in my office? No, I don't, because I'm a busy, top-end, fast-moving prosthodontist. In my office, my dental coordinator, Jill, does this. Jill does all of my planning. She's a dental assistant with advanced training. Does that mean she's a doctor? No, it doesn't. She does the planning, and then, of course, I come in and I check it, and we go over it to finalise it. But she does all of the hard leg work, and I just come in at the end because I'm lazy. And then we see here what we have. Here are the implants with safety zones around them. Here is the inferior dental nerve. This yellow thing is a safety zone, and here is the implant within the safety zone. So you see we are in fact about 3 millimetres away from the inferior dental nerve. And so this is very, very powerful planning. Here you see the cross section. This outline is the tooth. The red is the template. The inclination of the implant, where is it? Coming out of the occlusal surface in the middle, isn't it? Because we want to be good little occlusal dentists. We want to be like gnathologists. We want cusp-fossa relationships. So here is our opening through the middle of the occlusal surface. And here we see over here, coming out through the middle of the teeth. Like that. That's what we want to do. And here we see the final stage of planning is the anchor pins. Those pins that hold the template in position while we do the drilling. They go through in between the implants you see here. In between the safety zones. They do not hit the implants, of course. So sometimes we might put only one anchor pin in. Sometimes we might put an anchor pin between an implant and a tooth. Or we might put one back here. Of course, in the posterior mandible, it's hard to manipulate back there. But we plan what is possible. Then what are we going to have for this case? What we're going to have is a prescription, which is a duplicate of what we planned, so that we know the size of implants, the diameter of implants, etc., etc. The next thing we're going to have is a template. We're going to have the surgical template and an index. The surgical template we have now realised is a very precise device. And what I want to emphasise is that it is absolutely a duplicate of the radiological template. The surgical template reproduces the geometry of the radiological template. Next thing we're going to have is all the instrumentation that we need, the various drills, etc. Next thing we're going to have is a master cast. So here is a master cast. Now, what do we do with that? Because we've got to make our bridge. So what we do is, here is the reconstitution of the master cast. This is the master cast that we made the radiological template on. We take the radiological template off, we cut out that section underneath where the implants are. Here we put the surgical template on with the implant replica screwed into position. We put in some silicone rubber to simulate the gum. We hold it in position down there, and we put in some dental stone to lock the implant replicas into position. And then when we take all of this off after it's set up and we trim it up, what do we have? We have our reconstituted cast. So here is the master model. We have made this master model from the surgical template, which was made from the radiological template, which was made on the same, from the data of the same cast. So you see, at step 1, 2, 3, 4, study cast, radiological template, surgical template, prosthetics. In this case, here is our prosthetic work. We are going to have these things. What are they? They are custom-made Procera zirconia abutments. And then we are going to, on top of that, have our prosthetics, which in this case is a zirconia prosthetic bridge, a zirconia framework which has been veneered with zirconia ceramics. What do we end up with? Well, we know we end up with a bridge that fits, definitely fits. We know the abutments fit. If you don't believe it, we'll take an X-ray and have a look. We know we have nerve safety. We can see the nerve away from the ends of the implants, 3 millimeters away, because that's what we planned. The occlusion, yes, if our work is accurate, if we have done occlusal adjustment on the radiological template, and if we have done the mounting of our models precisely, and if that template was absolutely in position when the radiological examination was carried out, if all of those ifs have occurred, this is the result that we will get. This is what is possible. You might say, wait a minute, you told us before that there is an error, a possible error of 1/3 of a millimeter, like 300 microns, 200 microns, 400 microns or something. So how do you take up the error with this here? Well, of course, how you take up the error is by that well-known dental material that we all know called crown and bridge cement. The implants are placed, the abutments are placed, they fit perfectly. If there is a little bit of error, that discrepancy, which in teeth in an hour is taken care of by the special guided abutment, in this situation it is taken care of by the cement. The cement takes up the error. Right, what about this zirconia bridge? Because these things are also a new development. Very strong, the strongest available ceramic material. How thick does it have to be? Well, it's got to be 0.8 millimeters thick. So up until a level of 3 millimeters above here, we've got to be 0.8 millimeters thick. Thereafter, of course, we taper them. So this one obviously is longer than that one, which is obviously longer than that one. But down here at this level here, all of them are at least 0.8 of a millimeter thick. Up here, of course, that might be tapered down right at the very top. That might only be 2, you know, or maybe 0.5 of a millimeter thick at the very periphery right up here. But of course, crown and bridge work, we know we also need a decent height of abutment, don't we, for cementing, because this is a cemented restoration. What about the bridge length? How long can these bridges be? Well, the maximum number of abutments is 4 for this technology. That means you can have a 6-unit bridge. Well, how can you have a 6-unit bridge with 4 abutments? Well, you can have a couple of pontics. They may be cantilevered pontics, or they may be intermediate pontics between abutments. So the critical thing is the number of abutments, not the number of units. How much occlusal clearance do you need on top of the abutments? 2 millimeters. That's for the material strength of ceramics and for veneering the zirconia framework and for putting in your ridges and your grooves and your cusp form and all of that sort of stuff. So, as I said before, for Procera, all ceramic cemented bridge work with respect to Noble Guide, minimum height 5 millimeters. That's 3 millimeters for the abutment plus 2 millimeters for the bridge. So keeping in mind then, what about this? When does the doctor decide to go the temporization pathway? When would we want to do that? Okay, the same as in normal crown and bridge work, or the same as whenever we want to do provisional restorations in full arch bridge work. If we have high-end aesthetic situations, if we're not sure about the occlusion, if we're not sure about the function. Any of those situations, of course, we will go to the temporization pathway. If we want to do soft tissue manipulation situations, which we often do in aesthetic dentistry, we may not want to finalise our bridge and do teeth in an hour. We might want to use Noble Guide for the surgical aspect, and then of course put on a temporary provisional thing that we will play around with over the next 2-3 weeks or the next 2 or 3 months. And during that time we will modify the aesthetics. We will modify emergence profile, submergence profile, make sure the patient can clean with proper access for plaque control. All of those possibilities that we might want to play around with. If we want to do that, we don't want a permanent restoration, we want a provisional. So in those circumstances, we will elect to go down the temporization pathway here. That's what we will do. Okay, you've been very patient and very good, and I'm now going to begin to perhaps summarise and look at a few other things that we're doing that are important. Some of the current clinical research projects on protocol variations that we're doing. You know, we're still learning. This is still relatively new technology. It's only been around for about 3 years. There are not tens of thousands of cases done yet. There are only probably many, many hundreds of cases done. So we are looking at a number of things, such as we see here, a research project on split mouth design, comparing and contrasting final and provisional pathways with respect to advantages and disadvantages in some cases. Mini flap protocols, why are we looking at that? Well, a lot of dentists, of course, are concerned about using this sort of drilling procedure. We drill down a sleeve and we drill away a circular piece of mucosa. And many dentists think this is sinful. They think that mucosa is so important to me aesthetically. I want that bit of mucosa. I want to do some little maybe interdental papilla mini flap manipulations. And I don't want to lose that tissue. Okay, that is a valid point in high-end aesthetic dentistry. So we are adapting some of the protocols to learn how to best provide for that. Another example is the simultaneous bone graft and implant placement procedure, where we can plan a case to put implants in and we see there isn't enough bone. So why can't we use this planning to put the implants in and also do a bone graft simultaneously? So that's another possibility that we're working on. And we reckon that maybe, you know, a year, 18 months from now, we will have protocols on these things that will be of interest to everybody. Just to talk about one of them, let's just sort of look at one of these things that we're doing, where, as you see on this diagram, what we are doing here is we're going to compare a screw-retained final prosthesis on one side of the mouth against a temporization pathway and a screw-retained device on the other side. And so to show you the sorts of things here, like this lady. Here is her panorex. Looking at that panorex, you can see what? Not much bone. Not much bone. She wants to get rid of a partial denture. Okay, she is going to have a sinus lift, isn't she? She's going to have a pre-implant sinus lift. But what we're going to do is we're going to do that, and then we're going to do a split mouth design on her. So that panorex shows the necessity for sinus lifting. And here you see the conventional sinus lift that we do at our centre. This treatment in this instance is being carried out by my oral and maxillofacial surgical colleague, Dr. Brent Allen. Some of you have seen Dr. Brent on some of our other clinical demonstrations for teeth in an hour, and he is a beautiful surgeon. And you see up here, look at that, isn't that beautiful? Here is his window. Here is that sinus lining. Perfect. No perforations, nothing. Anyway, here is the patient. Here we see before and after the grafting. And then here she is in the mouth, and we see a better, certainly a better morphology of her ridge. So, work up again, step 1. We're doing the template. Very important, that's why I'm emphasising this. Some of you people there might be saying to yourselves, we're sick to death of you telling us how to make a surgical template. You think we're stupid? No, I don't think you're stupid, but I know that every training course we do, only about 5% of the people that do the training course know how to make a template properly. I know that. That's why I'm emphasising this. A lot of, say, crown and bridge dentists, they think, I don't like making bits of acrylic junk. I don't do stuff like this. Well, you can't do this sort of guided surgery then, because you have to do this sort of fundamental prosthetic assessment if you want to do this sort of treatment. So here we see her. Here is the template in position, and we've got some teeth on. And then we try that in the mouth. We're going to try it in, aren't we? Here. We check her occlusion with a shim stock. Then we put in the template, we check the occlusion again with a shim stock. If it does not hold, we're going to do occlusal adjustment back there. So we get very precise occlusal adjustment here. Then we put those radiological markers in. Then we go back to the dental lab, and we're going to open up the vertical dimension, and we're going to add acrylic on the front, as we've done here, to open her vertical up so that the teeth do not overlap. And we put in an inspection window, so that when this goes back to the mouth, we can look through there. We can put our probe in. We can go scratchy, scratchy, scratchy to make sure that that probe is all the way in there, and that the device is not distorted. And then the radiological markers, we check that. What's the next thing we're going to do? You guessed it, yes. The occlusal index. We do that. Then she goes off for her radiological examination. And what do? Here you see, nicely depicted, you can see here the radiological depiction of the sinus lift. Here's a bone plate. This is where the screws were put in to hold that bone plate in position. And here is the cancellous bone that was packed in there. And here you see the template in position. And here you see we're planning the implants. In the cross section, here you see, here is the sinus. Beautiful sinus. Here is the window that was elevated up. Here is the bone that was packed in there. Here is the bone plate. Here is the particulate bone. Here is the implant. Here is the occlusal outline. Here is the access hole through the central fossa. We do all of that planning. Here we see the implants, 1, 2, 3 on one side, 1, 2, 3 on the other side. Here are the anchor pins put between the implants, not to violate the safety zones. So you might say, well, I don't fully understand all of that yet. Well, of course not. If you did, you'd be Einstein. You'd be some sort of genius. Where we go from here is we go and do a training program. We do a one-day training program on the Procera software. That is the key issue. Here again, you see the finalised planning. Each implant has got a yellow box around. That's the safety zone. Here you see the anchor pins going in between the implants so that they don't hit them. And then, here we are. On the one side that we're doing the teeth in an hour, here we have our preformed bridge. This here, I'll put the bridge on here, and it's not screwed down. That is to show you that it's just sitting there. And you see slight space. Here it is screwed down. Here again is the guided abutment. As we said, that guided abutment goes in here. As you do the screw up, as you go in here and do the screw up, what will happen is that this section will pull the bridge down. These flanges will expand sideways, and these horizontal grooves will lock into the titanium receptacles to make sure that fits. So that's what we do on her one side of her mouth, and here she is. So here you see the sinus lift. Here's the bone grafting. Here you see her teeth in an hour bridge. It's an all-in-one titanium framework that has a plastic veneer. and it has the guided abutments. Now you might say, I don't want a plastic veneer. I am a ceramic dentist. I want a ceramic veneer. Well, you can have a ceramic veneer. You can have whatever you like. You can process ceramics to the titanium instead of a plastic material. And here are the guided abutments on that side. And on the other side, what have we done? Well, the other side, this is our split mouth design. On the other side, of course, we used the planning to place the implants. Then, on this contralateral side, we have put on impression copings, and we've taken a radiograph to ensure that they are all in position, and then we will do a pick-up impression. And then we will make an in-house acrylic provisional bridge. We may do this in 2 hours while the patient waits, or we might just put on a healing abutment and bring the patient back the next day and put in the provisional bridge. We are not under enormous pressure. And so what we're doing here is a research project to compare and contrast the both sides with respect to advantages and disadvantages. With respect to low impact aesthetic demand, we don't think this is an issue. We would go for teeth in an hour and a guided abutment every time. However, for aesthetically demanding cases, for anterior cases that shows the patient's gums, and in high visibility cases, etc., we would elect to go the provisional pathway. So let's begin to summarise up now. What are the benefits for our patients? Well, minimally invasive keyhole surgery, minimal pain and swelling because we're not raising flaps, we're not pulling up periosteum, we're not waving around the bone with suction devices, we're not putting in sutures, we're not doing all of those things that cause some postoperative swelling and discomfort. And of course there is reduced chair time. Patients like to spend the minimum amount of time in a dental chair. There is a cost saving. Yeah, sure there is. The patient can go right back to work the same day. We've treated some television announcers that went 3 hours later back to the studio to do their television work. Immediate return to work and social life. Fast treatment, immediate function with teeth in an hour. So these are all some of the possible benefits to a patient. What about for the dentists? What about for you and me? Well, some important benefits. Increased predictability and safety. First of all, with the planning, as I showed you on that mandibular case, the safety zones and all of that stuff, there is that degree of safety. Then this is translated into reality with the surgical template. Because you see on this template, these sleeves, those sleeves that are in the template, they serve as stops for the drilling instrumentation. Each drill has got a drill stop on. And then of course the anchor pins hold the template in position. The template's very stable. The inspection windows to ensure that it is properly in position. And looking at this view of the template, you see here the drill stop engaging the top of the sleeve exactly. And then that means you cannot over drill. If the template fits properly and is stable, you cannot over drill. You cannot prang nerves. You cannot come out the side of the jawbone and involve some other important structure. This is just impossible with controlled planning and precision surgical template manufacture. So this increased predictability and safety, ladies and gentlemen, for you and I is important. The pre-production of prosthetics. We've got a number of flexible possibilities here. There is teeth in an hour that we've been talking about with these guided abutments. Here is this case we talked about. Here's another one. Here's a 3-unit bridge with 1 Pontic. Same idea. All in one framework, aesthetic veneer, 2 guided abutments. Or we can go to the other possibilities we've talked about. We can go to Procera, zirconia, custom-made implants with a bridge. I'm giving you a little exam here. The exam I'm going to ask you quickly is, how much vertical dimension do you need for this? You said 8, good. How much do you need for this? At least 5, good. So anyone that told me 8 or 5 then, they have passed our examination, and you will get a special certificate sent to you from me, a certificate of distinction. Or you might say, sorry, I don't want any of that. I'm not interested in this teeth in an hour. I want to go the provisional pathway. Well, you can do that. You can either use zirconia abutments, you can use titanium abutments, you can use temporary abutments, you can go to an abutment level, you can go to the implant level, you can do whatever you'd like to do. So what this then means, this gives us a global total concept solution. This isn't just a single thing. This is multiple pathways for final treatment, for provisional treatment, for ceramic bridge work, for titanium plastic bridge work, for conventional bridge work with abutments, for conventional bridge work direct to the implant with no abutments. This total concept is there for us to decide what is the treatment of choice in this particular case, what is in the best interest of our patient. Final thing to think about, it's simpler. This means reduced inventory. All of you ladies and gentlemen out there, I bet you if you go into your clinic and you look under the clinic sink, you've got boxes of stuff that you've bought. You've got old abutments, you've got old implants, you've got old drilling things, you've got all sorts of stuff that you've bought that now you can't trade in, that now isn't worth very much. Because you needed this inventory in the past, because you didn't really know what you're going to do. With Noble Guide and Procera software planning, you can zero right in at a high level of accuracy, and you know exactly what you need, and all you've got to do is order the hardware for that particular case. You don't need to carry an extensive inventory anymore. Final few points about case selection. All of the traditional inclusion and exclusion criteria for implant treatment apply, of course. There's no different. You've got to have sufficient jawbone, of course. If you're going to do bone grafting at this point of time, the protocol is do the grafting and wait for it to have healed before you do your workup. Don't go jumping in too early to do dentist scans or CAT scans. Don't go doing a CAT scan before you graft, then another one after you graft, and then another one in the next jaw next year when you do the other jaw. Don't go doing that. It is possible with some CAT scan programs for a patient over the time frame of, say, 1 year to 1.5 years, having 3 or 4 CAT scans, they can end up having a sum total radiation dosage equivalent to about 300 Panorex x-rays. Think about that. If that was you, would you like that? The final thing which we haven't talked about much is the oral opening for this instrumentation. To get these templates in and to get all of the hardware in, a patient has to open up 40 millimeters at least, preferably 45. Now you might say, well, if they can't, can I treat them? Well, yes and no. If supposing in the opposing jaw they have a full denture, well, you can take that out, of course, and you've got another 10 or 12 millimeters of opening. The other thing that we've learnt with trial and error is that we can assemble the instrumentation into the template out of the mouth and then put it in, instead of putting in the template and then going through the instrumentation. This means after each step, removal, reassembly and back in. So that takes longer to do, but that is something that can be done. But certainly if a patient comes in and they've got teeth in both jaws and they've got limited mandibular opening because they've got some temporomandibular joint dysfunction and they can only open up 20 or 30 millimeters, well, you can't do this sort of treatment on those patients. The final thing I'd like to do, ladies and gentlemen, is to acknowledge all of my team that I work with here in beautiful Western Australia. And that means our surgeons, it means our implant dentists, our dental technicians, our surgical assistants, our team coordinator, our referring network dentists. All of these people put together make this possible. I certainly do not want to give you the impression I am a one-man band. I am not. I am a member of a team, and together we can do these things better than doing it singly. Finally, I want to just recognise the historical development of guided surgery, because this has occurred over a long time. And there are three issues here. One is that the original software planning was developed by Professor Daniel van Steenbergen and his group in Leuven in Belgium. It was called Literim. And there are references in the literature going back about 4 years on Literim. Then the Van Steenbergen group combined with the Mats Andersson group in Gothenburg, and you all know Mats Andersson. He is the inventor of Procera. So these two major areas then fused together, and as a result, Nobel Guide and the Procera software program was developed. And so today, the commercial reality is if you want to get involved with this, you would use Nobel Guide and Procera software, and you can do appropriate training courses if you would like to. Okay, ladies and gentlemen, that ends our formal presentation, and thank you for your attention, and maybe if anyone has any comment to make or some discussion, we would love to do that. One question that we could talk about, which I noticed before, was to do with scatter. That is, what do you do about especially post and cores in teeth and a lot of crown and bridge work already existing and getting scatter from that? Well, the answer is, if possible, remove it. There is no magical radiological program to eliminate that. So if you can't remove it, which often you cannot do, of course, because the work is already there, what you do is work around it. A post and core in a tooth is the biggest problem. Crowns are less of a problem, because in the planning, what we will do, of course, planning of the implants, we can get away from that scatter and we go beneath the level of it. So there are ways around that. So here's another question. What percentage of bridges do not fit at time of placement? Well, one answer to that is 100%, or the same answer might be 0. Getting back to what I said about the difference between virtual reality and clinical reality, there will always be a few microns of difference. So depending on how exact you are with respect to your particular precision in crown and bridge work, will answer that question. The point is that it doesn't matter. The guided abutment will cater for that discrepancy. Now, of course, there may be some dentists in the world that say, I'm sorry, but I can't accept that. I don't want to use that or whatever. Well, of course, then we would say to those dentists, well, what you would do is don't use teeth in an hour. Use Procera software for planning and placement of your implants, and then use conventional, traditional crown and bridge methods from a surgical level impression that you will take. However, as far as we are concerned, we like Nobel Guide, and certainly with the guided abutment we have satisfactory fit in terms of the radiological and clinical assessment of what satisfactory fit means, meaning radiologically all the components are closed and there is no error or minimum error, and no error of clinical significance. Okay, another question that we've got is, in the partially dentalism case, how to transfer the computer-based position of the 2 guide pins to the surgical stent. That is done automatically. in the software planning. You plan that. So just as you plan the implants, you also plan where you want to put the anchor pins. And then when you transmit that information to the manufacturing facility, your template will come back with your anchor pins in exactly where you have placed them. Now, keep in mind with the software planning, there is no quality control elsewhere. You are the quality control. So where you place the anchor pins, that's where you're going to get them. Of course, in the earlier stages of development, the earlier developmental phases of the project, there was a lot of quality control. But now, at this point of time, now that the procedure is released to the marketplace, you are responsible for that. On the other hand, in your early cases, if you need help, you can communicate with other people. You can communicate with us here, in working hours here in Perth, not at night like it is now, because I'm asleep at this time normally, but during working hours you can communicate with us, you can transfer your stuff to us, and we can advise you. So plenty of help is available, or your regional Noble Biocare product specialist can help you. So essentially the important issue is, don't worry about that. It is incorporated in the planning. It's a discrete planning step, and it is not problematic. Another question is, it seems to be some kind of digital to analog technique to convert information in the CT software to real objects. How was this achieved? Again, I'm not absolutely clear on what all of that means, but everything is achieved in the software planning. The software planning is really fantastic. Unfortunately, with this presentation, we could not accurately show you the 3D capability in 3 dimensions because we can't show videos in this sort of presentation. But with this software planning, you can move the jaw totally inside out 360 degrees. You can put implants in back to front, upside down, sideways, any way you want. You can look at all of the anatomical structures from any direction you want, and you have total flexibility. So with respect to digital planning, it is all there. No problems with that. Regarding the immediate function prosthesis cases, what is the success rate? How long is the time frame you use to judge your success rate? Okay, with respect to success rates, we can say totally accurately that our success rates is in the high 90%. There are 2 things with success rate to consider. One, of course, is cumulative success rate of implants, and the other is the success rates of the actual prosthesis. So certainly, occasionally an implant might be lost. I can tell you, so far in Perth, touch wood, here, I'm touching wood, boom, 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 touch wood, we haven't lost an implant yet, but we will. Sooner or later we will. That's normal experience. So some of the centres around the world have lost an implant. But as I said, the success rate of implants is in the very high 90s, like 98% plus. With respect to monitoring long-term success rates, well, of course, there are ongoing studies determining marginal bone loss, soft tissue parameters, and all of those other things that we look for with respect to success. Our experience so far is that with the fully edentulous patients, we are now almost at the 2-year level of follow-up. With respect to the partially edentulous, the first partially edentulous patient we treated early this year. With respect to the single tooth application, our first single tooth patient we treated 3 months ago. So in the partially edentulous patients, at this point of time, we do not as yet have 1-year follow-up. But with respect to our short-term experience, we are very encouraged with this. We have lost no implants yet in any of our partially edentulous cases. Obviously, as with everything else, with the passage of time, there will be a failure rate, like there is with any implant treatment. My feeling at this point of time, and I know the feeling of the other centres, is that we expect a lower failure rate with this than what we do with our conventional immediate function cases. The reason for that is greater precision of placement. The important issue here is that safety zone, that yellow section that we showed on the planning. That safety zone is so important in indicating to us that we have not perforated the bone. If we have a dehiscence or we have a fenestration, we know about it. If there's no bone on the labial surface of an implant, we know about it. So the implants placed with guided surgery are inherently, potentially more stable. And this is one reason why we think that the long-term success rate will be, in fact, superior to conventional immediate loading procedures. Okay. Another aspect of that question, of course, is that with respect to the placement of the implants and the stability of the implants, we can still use all the things that we normally use. We would still use insertion torque with respect to assessing stability. We could still use RFA if we want to use that modality. So we can still do all of those things. Another question is, why do you link the 3 abutments rather than have single individual units with respect to ease of cleaning? That is a good point. Certainly, yes, in critical aesthetic cases and for ease of cleaning, separate tooth implants are fine. However, we routinely down the posterior part of the mouth certainly generally splint the implants together. There is no problem with plaque control because we have interdental spaces that will cater for a small interdental brush. And as you know today, the variety of interdental brushes that are available is truly fantastic. 5 years ago, many of them were big and gross and bulky. Today they are extremely fine, so that we have interdental brushes that would in fact go between mandibular incisor teeth. So this is a clinical judgment. If you want to do single teeth, not a problem. If you want to splint them together, not a problem. Your treatment planning on that will be as a function of your clinical preference and what the patient wants, and with respect to the idiosyncrasies of the particular case. So no real issue there. Another question is, do you personally prefer external hex or internal connection when using Noble Guide? My answer to that is 6 of one, half a dozen of the other. As far as I'm concerned, both forms of connection are satisfactory prosthetic connections. I have no issue with either, so I don't have a preference. I may have a preference for the type of implant. For example, I may want to use a tapered implant sometimes between tooth roots, in which case that may mean that I will go for a replace tapered implant, which might mean I'm going to have an internal connection. So also keep in mind that this business of internal connection versus external hex is probably more of a real question on single teeth than what it is on bridges. Because if you're going to use bridges, and if you're going to use implant level bridges, you are not going to fully engage an internal hex as you would with an abutment. That is, if you're going to the implant level. So there's also that consideration. But I don't wave a particular flag for one or the other. I think, as I said, 6 of one, half a dozen of the others, and it really is up to a consideration of the individual operator and maybe some variation on the individual case. But I certainly see no place in my practice for saying I am an internal connection man or I am an external hex connection man. I don't see that. Another possible question from Hong Kong. Oh, hello Hong Kong. I've got a lot of my good friends in Hong Kong. In case of surgery under general anaesthesia, what is the precaution, particularly the occlusion? Well, there is no particular precaution under local anaesthesia, because we have treated all, like the case I showed you of the guy in the mandible. He was done under local anaesthesia. I didn't show you his clinical shots because unfortunately we couldn't show videos, because with this sort of presentation you can't show videos. And one thing which I must admit, ladies and gentlemen, and I would suggest all of you keep in mind with respect to your continuing education interests yourself, if you video something, also take photographs of it, because we've got a lot of stuff on video but we don't have photographs of it, and you need to have both. Like for example, this presentation, I would like to have shown you clinical examples of that lower mandible. But with respect to the point of local, because there is a great deal of predictability and safety with Noble Guide, I don't have the same preference, say, for a general anaesthetic that I might normally have over the inferior dental nerve of a borderline case, because we know with the planning that we're safe. We cannot over drill. Even if the patient moves, even if the patient jumps up and down, you can't over drill, because the sleeve in the surgical template will prevent you from over drilling. So there are probably greater numbers of patients that you could treat with local, with guided surgery, than what there is if you're not using guided surgery. Right, another question. Is it possible to do simultaneous bone graft when using Noble Guide? We are currently, as I said, working on a couple of projects testing this. And certainly a year from now, we will expect to have protocols to share with you. At the present time, we would say no. But we're looking on two aspects of this. One, augmentation, say, of the labial part of the anterior maxilla, augmentation of the labial plate to, say, increase ridge dimension labiolingually. That's one. The other thing that we're working on, of course, is doing osteotome sinus lifts, or osteotome lifts, say, into the nasal area. Those sorts of things are relatively promising to be done with this sort of surgery, because you can do that down the guide sleeve. So we expect to have protocols on that faster than what we will have on the others. So certainly I reckon a year from now we will have some of those protocols so that we can do this simultaneously, which will make it very attractive for a lot more cases. How much angulation difference of implants will this system accept? Really doesn't matter. You can put implants in at any angle. If you were in Las Vegas, at that fantastic World Congress in Las Vegas, you would have seen perhaps a Noble Guide being used experimentally on the placement of zygomatic implants by Professor Chantal Malavé in Brussels in Belgium. And of course the angles of those things to each other, and with respect to two zygomatics back here and then anterior implants here, huge differences, 45, 60, 90 degree angular differences. Doesn't matter. The point is you can plan a template and you put sleeves in and you can go in at all sorts of angles. For example, another angulation technique which is so important, the all-on-4 procedure, developed by Dr. Paulo Malo in Lisbon in Portugal, tilting lower mandibular implants or tilting sinus implants anterior to the wall of the sinus. This can be done with a Noble Guide. So the angulation is not a problem. This technology is well suited to angulating implants. Can we use Noble Guide with immediate placement after extraction? The answer to that is that, again, this is another thing that the protocols are being developed on. And again, probably 6 months from now, 6 to 9 months from now, we will have good protocols on that. So the answer to that absolutely will be yes. At the present time, that is still under development, but it is a reality. How to reduce failure rate due to masticatory occlusion forces after immediate function placement of full mouth bridge in terms of diet, occlusal angles and oral hygiene. Okay, from Singapore, this question. Well, certainly, of course, this is a fundamental question with respect to immediate loading. And with a full arch bridge, we have cross arch splinting, which is an important design criteria. So our normal instruction to a patient is a soft diet to begin with. We keep our patients on a soft diet, gradually building up over a period of 6 weeks. Why 6 weeks? This is an important biological time frame. It takes 6 weeks, as you know, for healing callus to occur and for interface development around the implant to get to a certain level of strength. Just like if you break your leg. You can't run out and kick a football 2 days or 3 or 4 days after breaking your leg, can you? You have it plastered up and you hobble around on crutches and then you get a walking stick. And after 6 weeks, you are almost back to normal. Similarly with immediately loading implants, that 6-week period we have to go very gently whilst we are getting stability at the level of osseointegration, secondary stability, reorganisation of the interface of the implant. At the 6-week level, we know that woven callus has formed and the patient then is out of the danger zone. Most implants that are lost very early on, within the first 3 months. So that's number one. Soft diet for 6 weeks. What does soft diet mean? That means soup. That means vitamized food. It means fish. Maybe after 3-4 weeks it means chicken. It doesn't mean T-bone steak and stuff like that. Plenty of vegetables. So be careful. The other thing, of course, is besides the function of food, taking into account those other things. The control of parafunction is a very important issue. The recognition of parafunction before treatment and the employment of some sort of parafunctional control therapy during the early healing phase. The design of the occlusion is important to make sure we get group function on cross-arch bridges wherever possible, so that if a patient does parafunction, we have bilateral stability. The use of occlusal splints, soft rubber occlusal splints, rubber on the fitting side but hard occlusal surface on the occlusal side. So all of the things that we consider for the normal control of parafunction, we absolutely have to consider that with respect to implant patients as well. The other final point to touch on here is occlusion. What is important is what is in the opposing arch. The worst possible occlusion to have is ceramic to ceramic. Never ever go straight to ceramic bridges in both arches. Preferably never do it anyway. We believe that the best occlusal scheme is ceramic in one arch and plastic in the other arch. Okay, the important thing is if you've got ceramic in one jaw, acrylic in the other jaw, or plastic in the other jaw, that means the acrylic will wear. And with the passage of time you can redo that bridge. Classically, what we are doing is PFM in the maxilla with a hybrid bridge in the mandible. Why in the maxilla for PFM? Because that is aesthetically more demanding. That shows up most. Number one. Number two, A PFM bridge is considerably more expensive to make, to redo, than what a hybrid bridge is. The other advantage of having ceramic against acrylic is if something is going to break, guess what? What do you think is going to break? If you're biting PFM against a hybrid bridge, what is going to break, of course, is the plastic. That's going to break and wear out. The other thing too with that sort of hybrid arrangement, if you're considering maybe you'd like an occlusal splint in a patient, well, perhaps with the arrangement of ceramic in one jaw, acrylic in the other, you don't need an occlusal splint because the hybrid bridge will take up some of that stress. Whereas if you've got ceramic against ceramic, problem number one, something is going to give, something is going to break. It's going to be expensive to fix. Problem number two, you're going to definitely have to have an occlusal splint, a removable appliance, which a patient might find harder to tolerate. And problem number three, your maintenance over the long term, so much more expensive. What would you rather make? What would you rather have to repair or remake? A 12-unit PFM bridge or a 12-unit acrylic tooth hybrid bridge? I think we all agree what the answer to that would be. Right, another possible question. From Hong Kong, is articulator mounting obligatory in single tooth and freehand saddle cases? My answer to that question is it obligatory for you in your normal crown and bridge work? Because crown and bridge on implants is not any different, ladies and gentlemen, to crown and bridge on natural teeth, is it? So whatever your guidelines normally are, use them. The advantage of an articulator is that it does a lot of the work for you. There must always finally be checking of that work in the mouth and zeroing in and adjusting of it in the mouth. So yes, I like articulators because it gets my occlusal scheme pretty close. Then I go to the mouth and I just have to zero it in and do minor adjustments. But if you said, do I have to use an articulator to do a single tooth implant crown? Well, I told you the answer before. Do you have to use an articulator to do a single unit PFM crown on an anterior tooth? Or can you adjust that in the mouth? Can you do that with handheld models? It gets down to the skill of your laboratory, doesn't it? It gets down to how good your models are, how positive they are. It gets down to how good the technician is with respect to rubbing models against each other. Is he going to abrade them, abrade those occlusal surfaces, as compared to being careful on an articulator? So I think I've covered that question. Another possible question, interdental brushes. I had a patient who had the habit of using this over a period of 3 weeks after placement of 6 implants supported Noble Direct Groovies. It caused a failure of 4 implants and loosening of 3 in the upper 6 implant supported bridge. Your suggestion and view, please. Well, my suggestion is something was wrong somewhere. The only way that could have caused a failure is that there wasn't enough space for the brush, or the brush was too big, or the patient was spearing themselves with the brush or doing something traumatic. I've never heard of that before. It is fundamentally important that you must have space there. I do not believe that interdental brushing is responsible for implant loss. It could be a whole lot of causes. I don't even think that the brushing would be an ancillary or a secondary cause. The only way I could envisage that happening would be that there was absolutely no room for this brush, and the patient was in there with some great big brush and he's banging out in there, whack, 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 under huge force and pressure, causing a lot of bleeding and trauma. And any patient in their right mind would be back to the dentist. And I would raise one further consideration with this, and that is the instructions to the patient for follow-up. Don't put an implant bridge in, give the patient instruction in hygiene and say, I'm going to see you in 3 months, or give me a ring if you have a problem. In our practice, we have that patient in within 2 to 3 days. Now, okay, I'm a very busy dentist, and maybe you are, and maybe you might say, listen, I don't have time for that. Well, you don't need time. You've got dental assistants. Maybe you've got hygienists. But even your dental assistant can get the patient in the next day or 2 or 3 days later. You should also telephone the patient the next day. Say to the patient, how are you going? How is everything? Anything hurting? When you do plaque control, is it painful? And you run through a checklist. Communication, that is the secret. Communication with the patient, phoning the patient up the next day, getting them in after a couple of days, let your dental assistants do all of that stuff, and the patients love it. You're looking after them. Everybody wants to be loved. They want to be called. That's what's going to separate you from your competitor down the street. And that way you won't have such a disaster as what this was, which was certainly very, very unfortunate. From Hong Kong. Oh no, I've read that in the messages. Right, another question. According to the software guidelines, the yellow zones around the implant during treatment planning is 1.5 rather than 3. Yeah, 1.5 all the way around. That's right. Yes, that is correct. Now, with respect to, say, further tracking or further protection, for example, over the inferior dental nerve, you have that yellow zone, and you also have where you track the nerve. So you can track the nerve wherever you want to. If you, say, track 2 millimetres above, like we do, 2 millimetres tracking zone plus the safety zone around the implant of 1.5, that gives you 3.5. So the tracking of vital structures, you can set that target, you can set that criteria yourself as to how close you want that to be. So there is a lot of flexibility, and certainly that 1.5 is a lot of flexibility. And some very skilled people, you know, they will use that 1.5 zone directly above the inferior dental nerve, because with a software planning program like the Procera software planning, that is a new level of accuracy over and beyond what we did before we had this sort of planning software, where before what we used to do was trace. We would get our CAT scans and we would do tracings and we would use the rulers to measure that. So we're in a new era of planning at the present time. This is our final question that we're going to talk about, and it is this. Using Noble Guide onto an edentulous ridge without attached gingiva, is that okay? Well, this is a very, very good question, and of course, if there is no attached gingiva, you certainly don't have any worry about losing your keratinized mucosa. So yes, that is okay. We know that the health of attached gingiva versus non-attached gingiva around an implant can be comparable, and it is dependent on plaque control and proper maintenance. If, on the other hand, you say, listen, I want attached gingiva, well, you might have to put it there. You might have to do some preliminary soft tissue graft or something. But we have got no concern about unkeratinized mucosa or movable mucosa adjacent to implants necessarily. It boils down to the crucial fact of, one, can the patient maintain it or is it painful? We would do some corrective surgery in a situation like that if the patient says, I can't brush or clean or maintain plaque control over this area because it is so soft and friable that I can't do it. In those situations, we may do some soft tissue grafting either before surgery or even after implant installation. If it's after implant installation, that generally involves reversing the situation, placing a cover screw and doing a graft, and then 6 weeks later going back and reconnecting the prosthetics following the placement of that graft. Well, ladies and gentlemen, thank you for your attention. It has been my great pleasure and privilege to have this opportunity to talk to you around the world. I know a lot of you listening tonight. I have met you before, and I would certainly hope that we meet you again. And for those that I haven't met yet, I hope that we meet you in the future. So without further ado, good night from here in Perth, Western Australia. Thank you.